Dear friends, first of all, I would like to express my thanks to Professor Liakopoulos for inviting me and to Professor Goumelos for his nice introduction. Unfortunately, I had some problems with my slides, so not all of them will be seen today, but I still believe that I will be able to show you something, because there was really a progress in the field of lupus nephritis in recent years. So these are my disclosures, and I always start with the history. So I would like to stress that Central Europe was instrumental in the description of systemic lupus and differentiating of systemic lupus from lupus vulgaris, skin disease. And this is Ferdinand Hebra, the founder of dermatology, who provided the first detailed description of systemic lupus erythematosus. And another person working in Vienna and well known because of AIDS, it was Maurice Capochet, and he also described in detail organ involvement in lupus. Of course, lupus is a complicated disease which is caused by the interaction of genetic, environmental, hormonal, and other factors. And these factors conspire together to result in autoimmunity and then finally in damage to different organs. And it is also known that in Europe, lupus is partly associated with the genes we inherited from Neanderthals. It is because you know that there is something like 2-3% of Neanderthal admixture in European population, which is not the case with Asians. So for instance, IRF5 gene, which is one of the genes increasing the susceptibility to lupus, was inherited from Neanderthals. And here is a nice slide showing simplifying the pathogenesis of lupus. So we had a nice lecture on DAMPs in the morning, and it's also, of course, very much related to that. So in fact, dying lymphocytes, which are subjected to apoptosis, are not effectively digested by the macrophages, and the exposure of nuclear particles to immune system finally results to the activation of autoimmunity. And what is important, and I will speak about it later, that there is a very important role of interferon alpha. The role is in changing immature dendritic cells to mature ones, which then activate both T cells, autoantigenic specific T cells, and plasma cells to produce autoantibodies. So what we see in lupus very frequently is so-called interferon signature. So it means the activation of several genes which are activated by interferon. And of course, when we know the pathogenesis, you see that there are many potential therapeutic targets in lupus. Some of them were tested, some of them failed. And I will then tell you what can be the most important reasons of the failure of several trials in systemic lupus. And of course, we will speak about lupus nephritis, which is one of the most severe and relatively frequent complication of systemic lupus. And I will concentrate on proliferative lupus nephritis, is type 2, type 4, because this is the most severe form of the disease. And here you see an old historical slide from the publication of Baldwin and Pollack from 1964. And you see that those patients who at that time suffered for diffuse proliferative nephritis, lupus nephritis, and were not treated or were only on low corticosteroids died, all of them within 2 years. And those who remain on high-dose corticosteroids, which is of course associated with many side effects, had still quite poor survival. So 5-year survival in type 4 lupus nephritis was only 25%. And so introduction of cyclophosphamide was an important breakthrough. And here you see, based on early studies from National Institute of Health, that survival without renal failure significantly improved. And also the rate of remission significantly increased. And it was Dimitrios Bompas, who was one of the leading persons at that time working in the United States and co-author or main author of many publications which really were moving points in the development of treatment of lupus nephritis. And this is another nice Greek study showing that what is very much important and what was missed in many clinical trials, that time to remission in lupus nephritis is quite long. It's in 50% of patients, it's 10 months. So it means that there are many patients who may reach remission in the second year of treatment. This of course, means that if you have a clinical trial which is with a follow-up of only 1 year, it is inadequate because you need to follow up the patients for a longer time. And another point is that if the time to remission is so long, it means that even in patients who are under treatment, there is still an ongoing damage. So it is something which is not satisfying, which we would like to change, but it is not easy and it was not achieved with any available medication. And another important point is that the patients are relapsing. Time to re-remission is even longer. And when the relapses are so-called nephritic, so mean not only associated with not only increase of proteinuria, but also with hematuria and increase of serum creatinine, even if the increase is temporary, they substantially worsen the outcome of the patient. So you see that 60% of relapsing patients reached finally end-stage kidney disease within 20 years. And here you see that generally, of course, with corticosteroids and cyclophosphamide, the outcome significantly improved. Probably you can see on this part. So survival of class 4 lupus nephritis, 17% in 50s, 60s, and 82% in 1995 with only corticosteroids and cyclophosphamide. So still not very much satisfying, but much, much better. And, but it was associated also with significantly lowered standardized mortality rate, which is comparing the mortality in patients with lupus with general population. You see that it was much, much higher in the 1970s and very much improved during 1990 to 200s. And this was because, namely, of lower rate of infections and lower rate of renal events. But currently, the patients are not dying because of active lupus nephritis, but they are dying because of cardiovascular complications, infections, and malignancies. And what also must be taken into consideration is that in patients treated with the regimen suggested by NIH in the 1980s, there was a very high rate of premature ovarian failure. And here you see, once again, Greek data, that this ovarian failure is associated with duration of treatment and cumulative dose of cyclophosphamide. And then we can measure ovarian reserve with based on serum levels of anti-Müllerian hormone. And you see that there are two main factors which are decreasing ovarian reserve. It's age, and the second is cyclophosphamide use. And in younger women, of course, they tolerate even higher doses of cyclophosphamide quite well, but in women older than 30, so still very young, you see that there is a very strong gonadotoxicity of even relatively low doses of cyclophosphamide. So it shows that even if the treatment is effective, it is so toxic that it should be in some way changed. And this was what was done in earlier studies in urolupus. It was in a study where the dose, cumulative dose of cyclophosphamide was decreased from 9 grams to 3 grams, and it worked. The efficacy was the same. Even long-term efficacy was the same, and there was a lower risk, 50% lower risk of infections. And this regimen originally suggested to be only for European patients, then expanded also to Asia and US because there were data that it works also in these populations. There were great expectations concerning the introduction of mycophenolate mofetil. Earlier studies suggested that it could be better than cyclophosphamide. But finally, I think it was a kind of disappointment because mycophenolate was really better than cyclophosphamide, but only in so-called other, mostly black patients. And you can see here that it was not because of efficacy of mycophenolate, but because of low efficacy of cyclophosphamide. And in European patients, the effect of mycophenolate and cyclophosphamide is completely the same. And it was also when maintenance treatment with mycophenolate was compared with azathioprine. So it seemed that mycophenolate is associated with lower risk of treatment failure and relapses in multi-ethnic population, but in European population, no difference. So azathioprine, which is much cheaper, is similarly effective as mycophenolate. And probably the greatest disappointment is that mycophenolate is not even better in terms of severe adverse events. You see that generally it was the same, and only the adverse events are different. So it is nausea, vomiting, alopecia in patients treated with cyclophosphamide, and diarrhea in patients treated with mycophenolate mofetil. So it's good that we have another drug to be used in patients with lupus nephritis, but it is not a breakthrough. And finally, some data, not only from Korea, but also from the US, showed that long-term outcome of those patients who were initially treated with mycophenolate mofetil may be worse than those who were initially treated with cyclophosphamide. So we are still not very much happy with mycophenolate, and we use it mostly for treating patients with not very active disease, not very advanced disease. What was also got from secondary analysis of some trials, such as MAINTAIN trial in the Netherlands, was that we can predict the long-term outcome of the patients based on the short-term response, short-term antiproteinuric response. You see here that those patients who had good outcome had decrease of proteinuria in the first months. And what was identified is that there is a level of 0.7 gram per day at 12 months, which distinguishes those patients with good outcome and those patients with poor outcome. And so when we published a review in Nature Nephrology Reviews 10 years ago, we stressed that we are in a much better situation than 50 years ago, but still patient survival and renal survival is not so good, is poor. Median time to remission is long, and the relapse rate is high, and these relapses have negative impact on the renal outcome. And so what is really new? There are two groups of new treatments. The first one are calcineurin inhibitors, and second, some biologics which are either approved or are now used in ongoing clinical trials. So starting with calcineurin inhibitors, we performed a small randomized controlled trial in only 40 patients 10 years ago, and at that time showed that cyclosporine is similarly effective in anything compared to IV cyclophosphamide pulses. And even when we look at extended almost 8-year follow-up of these patients, there was also no difference in terms of doubling of serum creatinine, preserved glomerular filtration rate, rate of proteinuria, and so on. At the time, cyclosporine was generally refused in Europe, but based mostly on the views of some rheumatologists who declared that there is no immunosuppressant activity of cyclosporine and that any effect is only hemodynamic and is associated with nephrotoxicity. But then, namely Chinese data from several studies showed that the combination of mycophenolate with tacrolimus is better than IV cyclophosphamide. And now we have new drug, voclosporin, which has the major advantage that it has much more predictable serum level associated with the dose than cyclosporin or tacrolimus, but otherwise, of course, works in a similar way. And there were two studies, phase 2 trial AURA LV and phase 3 trial AURORA 1, and then extension AURORA 2, showing the efficacy of voclosporin in lupus nephritis. And here you see the data from Aurora trials and Aurora trials. So you see that voclosporin was better in terms of complete remission. Voclosporin added to mycophenolate mofetil and corticosteroids. And this was the same concerning durability of complete renal remission in Aurora 1 trial. And here you see similar data only from Aurora 1. And here you see how it was during the time. And in terms of looking at predefined therapeutic target, we saw that UPCR lower than 0.7 at 12 months is associated with better outcome. And it was achieved only in 33% of patients treated with mycophenolate mofetil only, and in 52% of patients treated with a combination. So still not very good, but a bit better. And there was also a significant reduction of corticosteroids in voclosporin-treated patients, and the drug worked similarly in recent onset and later onset lupus nephritis. And we have also some data on long-term outcome showing that the effect persisted. So, and you can see here that the effect was a bit better in proliferative lupus nephritis compared to membranous nephropathy. And this is partly caused by lower number of patients in the membranous limb. But the second reason is, and I will return to that there were more nephrotic patients in membranous nephropathy limb compared to proliferative nephritis. And here you see cyclosporin was always a problem because when the patients were treated for a long time, there was a decrease of eGFR, but these patients treated with voclosporin for up to 2 years had stable glomerular filtration rate. And here you see that in terms of the slope of eGFR, which is now used in most studies, they had much lower slope of the decrease compared to mycophenolate only. So this is very important because it shows that it significantly prolongs the time until end-stage kidney disease. And it was quite safe. Yeah, there was no significant increase of adverse events. Now, coming to biologic treatment, I will shortly mention 4 drugs: rituximab, belimumab, obinutuzumab, and anifrolumab. So this is one of my broken slides, so I will miss it probably. So there was a trial called LUNAR, which was published more than 10 years ago, in which rituximab did not reach a significant difference compared to placebo. There was some trend in partial remission rate, but it was not significant. But the problem of the study, as I mentioned, was that it was a short study for only 52 weeks. And that they did not control in the beginning if the patients really reached B-cell depletion. So only 78% of patients reached complete peripheral depletion. And in those patients who reached depletion, the effect was highly significantly better. And another problem was that if you treat nephrotic patients with any kind of monoclonal antibody, part of the monoclonal antibody is lost into urine. And here you see that, for instance, rituximab half-life in patients with ANCA vasculitis, who have usually low proteinuria, is 23 days, and in patients with nephrotic syndrome, only 11 days. So it means that if you use standard regimen, the patients are definitely underdosed. And this mistake is repeatedly done, not only with rituximab, but with belimumab and anifrolumab, as I will show you. We measured also rituximab levels in our patients and come to similar conclusions. And we measured also rituximab levels in lupus nephritis patients, and they have a very similar half-life as the patients with membranous nephropathy. So decreased half-life and needed to higher doses than control patients. Then what appeared were very positive data on belimumab, which is a drug which inhibits main growth factors for B cells, so-called BAF or BLIS. And if B cells are not under the influence of BAF, they undergo apoptosis, and of course, these apoptotic cells do not proceed autoantibodies. So they were able to show in 2 huge studies in patients with systemic lupus erythematosus that belimumab was a bit better in all aspects. In fact, the numbers were very similar as to in a rituximab trial, which was, of course, much smaller. So another handicap of rituximab was it was tested only in 150 patients, and here there was 1,500. So the difference, 43 to 33%, was very similar. And based on this data, belimumab was approved already in 2011 for treating patients with active lupus nephritis, active systemic lupus, but not for patients with lupus nephritis. And in the sub-analysis of this original trial, there were some hint that belimumab can decrease proteinuria. And now we have data for that. This is one of my broken trials, showing that in BLISS, the trial BLISS-LN trial, which was a study in 440 patients with lupus nephritis, belimumab was better in terms of partial remission and complete remission, which was specifically defined, and also was better in terms of preventing relapses. So I will skip these slides. And here you see that even during the open label extension, the drug was better. There was a similar problem. Belimumab didn't work so well in patients with proteinuria higher than 3 grams per gram. It was not significant, probably from the same reason that the patients were underdosed. And here you see some data on obinutuzumab, which is a similar drug as rituximab, but is more effective and is used in patients with lymphoma resistant to rituximab and has a bit different action than rituximab. And it was tested in phase 2 trial also in lupus nephritis with positive data, and now a phase 3 trial is ongoing. And finally, I will say something about interferon and its inhibition in patients with lupus nephritis. So in the beginning, I said that pseudoviral articles activate through toll-like receptors interferon, and that interferon alpha plays an important role in the activation of lupus and lupus nephritis. And we have nice data. Unfortunately, the slide is also lost. That interferon signature is associated with severe course of lupus nephritis with type 3, type 4 nephritis. This is from the paper by Iwamoto, which was published about 10 years ago. And here you see that we have now several effective drugs which can suppress interferon or interferon receptor. And the greatest experience with interferon suppression is from the drug which is called anifrolumab, and is an inhibitor of a monoclonal antibody against interferon alpha receptor. There was two large studies published on patients with systemic lupus erythematosus. The last one, something like 2 years ago in New England Journal of Medicine, showing efficacy of anifrolumab in systemic lupus erythematosus. And currently, anifrolumab is already registered in Europe for active systemic lupus erythematosus, and the indication is almost the same as for belimumab. So the drug is available, but not for patients with lupus nephritis. We have some preliminary data for lupus nephritis from phase 2 TULIP-LN trial. But of course, this trial was underpowered for showing significant differences. But there were some positive actions of anifrolumab. For instance, anifrolumab worked, so it significantly decreased so-called interferon signature by 90%. So it means that it could have the positive effect on the course of the disease. And it was also shown in terms of non-renal activity and measured as SLEDAI-2K score. You see that patients treated with anifrolumab were much better. And also in terms of proteinuria and complete remission, which was higher in anifrolumab limb. And here you see that there were two limbs of anifrolumab, so-called basic and intensified. And basic was similar, there were similar doses from the beginning. In intensified limb, there was 3 times higher dose in the beginning. And all the intensified treatment worked, probably from the same reason that nephrotic patients were underdosed with basic doses. And of course, the major problem is that we are able to improve the course of the disease and definitely decrease the mortality and also decrease the rate of progression to end-stage kidney disease, but we are not able to cure the patients. They are relapsing after many years, and so the disease is still present and must be in some way treated. And probably it is because we need also to eliminate not only B cells but plasmablast and long-lived plasma cells. So currently there are some ongoing studies, phase 2 and phase 2A, with proteasome inhibitors, with anti-CD90 antibodies, which cover all B cells and plasma cells, with anti-CD19 CAR T cells, which are already used in patients with hematologic diseases or with allogenic stem cell transplantation. I must say that we had 2 patients with severe lupus nephritis who were treated because of lymphoma with a very aggressive regimen, and they are now in more than 10 years long remission. So probably we are under-treating some patients, which is on one hand good because we would like to avoid adverse events, but on the other hand we are not able to reach really sustained long remission or cure the patients. And finally, I will tell you something about the guidelines. So we have now 2023 update of 2021 KDIGO guidelines, and we have also 2023 EULAR guidelines. And in comparison with the older guidelines from 2012, we had only 2 options, either intravenous cyclophosphamide or oral mycophenolate, nothing else. Yeah. So now we have 4 options. Except for mycophenolate and cyclophosphamide, we can use calcineurin inhibitors as an add-on treatment in mycophenolate, or belimumab as an add-on treatment to mycophenolate or cyclophosphamide. And this was published in 2021, and when you compare what is in 2021 and 2023, there are almost no changes in this recommendation. There are only 2 ones. One is that, they say that you can also consider cyclosporine when voclosporin and tacrolimus are not available. It is especially for countries with low and middle income, because KDIGO always means that it is also important to give advice for those who do not have access to very expensive treatment. And the second is that there is no mention on rituximab, and there is a sentence that belimumab duration may be up to 2.5 years. And concerning maintenance treatment, what is new is that there is also an option to use calcineurin inhibitors or leflunomide, but it is quite uncommon in renal disease, and mesoribine, which is used only in Japan. And this is what is in EULAR guidelines. It is in fact the same, so I will repeat it. What is interesting is only how the targets are defined. So if the patient is responsive, it means that at 3 months there is a 25% reduction in UPCR, 6 months 50% reduction to at least 3 grams per day, and 12 to 24 months they should reach 0.5 to 0.7, with of course preserved EGFR within 10% from baseline. And finally, my last slide, what to do in patients who are not responding to the treatment. So first of all, similarly as in many other diseases, for instance hypertension, we should check the adherence to treatment. So these are young ladies, and very often they are not taking medication as it is recommended. If we are unsure, we should probably measure the levels of drug they are receiving. This becomes more and more available. We can do that on almost all drugs. Then, if we are still uncertain why it doesn't work and it doesn't seem that it is because of adherence, we should consider repeat biopsy. If there is not progression of chronicity or if there are not some other diagnoses, we saw that repeatedly that patients with lupus had some other glomerular disease, which was quite unexpected but can occur. And otherwise, we can only switch between the different regimens. So those who were initially treated with cyclophosphamide can be switched to mycophenolate and both. Or we can use these new regimens with voclosporin and belimumab if they were not used before. And in some patients who are refractory to everything, we still should consider rituximab, or they should be enrolled to ongoing clinical trials, or there could be probably also extended pulse of cyclophosphamide. And my last sentence, of course, the main question is, what is the position of these new drugs in the treatment? If there should be all patients or some patients treated with voclosporin and belimumab from the beginning, or if we should reserve the treatment only for those patients who are not responding to mycophenolate or cyclophosphamide. As these new treatments are very expensive, I think that there is probably not a realistic approach to treat everybody, but there could be some exception. And probably these new drugs, such as belimumab, could be used in young ladies to avoid the gonadotoxicity of the treatment, and probably also in old, frail patients, which may have increased toxicity of cyclophosphamide and mycophenolate. So I think that we are now in a great era of new drugs being introduced into treatment. I'm a great fan, especially of anifrolumab. And so we will have better chance to do something for the patients. But a major problem, as ever, is the increasing cost. And unfortunately, the treatment probably will not be available for all patients who could benefit from it. Thank you for your attention.